Healthcare, follow the money. Post 1. The $4.5 trillion machine. The United States spends more than $4.5 trillion a year on healthcare. That's nearly one out of every $5 produced in the American economy. It's more than the GDP of most nations. It is, by scale alone, one of the largest financial systems in the world. And yet, Americans routinely report confusion, frustration, and distrust when they try to use it. We pay more than any developed country. We fill out more paperwork than anyone. We argue about it constantly. And still, almost no one can explain, in plain terms, how the money actually moves. Ask a simple question. When you pay your premium, where does that dollar go? How much reaches a nurse? How much goes to administration? How much is negotiated away before a bill ever reaches you? How many entities touch a single claim before it's paid? The debate we usually hear is political. The structure underneath it is financial. Healthcare, follow the money. Post 2, who actually funds the machine? Before we trace how money moves, we need to answer a simpler question. Who is paying for the $4.5 trillion? The answer is not the government. It is not insurance companies, and it is not other people. It is a layered mix of employers, taxpayers, and individuals, often the same people wearing different hats. 1. Employer-sponsored insurance. Roughly half of Americans receive health coverage through an employer. That coverage is not free. Employers contribute a significant portion of the premium, but economists generally agree those costs are built into total compensation. In practical terms, health insurance premiums come out of wages, whether workers see the deduction directly or not. When premiums rise, wage growth slows. So when we talk about employer-based insurance, we're really talking about compensation being routed through a benefits system instead of directly into paychecks. 2. Federal government programs. The federal government funds several major programs. Medicare, primarily for seniors and certain disabled individuals. Medicaid, jointly funded with states. ACA exchange subsidies, veterans' health programs, federal employee plans. These are financed through payroll taxes, general tax revenue, borrowing, and state contributions. Again, the payer is not abstract, it is the tax base. 3. State governments. States share Medicaid costs and fund public health systems, university hospitals, and safety net services. That money comes from state taxes, income, sales, property, depending on the state. 4. Individuals. Even with insurance, individuals pay premium contributions, deductibles, copays, coinsurance, out-of-network charges. Out-of-pocket spending remains a substantial portion of total health expenditures. The first structural insight. Almost every American is paying into the system in more than one way, as an employee, as a taxpayer, as a patient. The same dollar may leave your paycheck as a premium contribution, leave your income as a tax payment, and leave your wallet again at the pharmacy counter. The system feels expensive because it is funded through overlapping streams, and we haven't even discussed where the money goes yet. That's next. Healthcare, follow the money. Post 3, where the money goes. Knowing who pays is only the start. To understand the system, we need to see where those dollars actually land. The $4.5 trillion flowing into healthcare doesn't go to one place. It is split across several major buckets, each with its own dynamics and incentives. 1. Hospitals. Roughly 30–35% of spending hospitals are the single largest cost center. Inpatient care, surgeries, ICU, long stays. Outpatient care, ER visits, imaging, labs, procedures. Facility costs, building, equipment, administration. Hospitals are complex organizations. Clinical staff, administrative staff, compliance, IT, revenue cycle management. Every additional layer adds cost, even if it doesn't touch patient care directly. 2. Physicians and clinicians, about 20%. Doctors, nurses, and other clinicians account for roughly 1/5 of total spending. Compensation varies widely by specialty. Fee-for-service models often reward procedures over preventive care. Here, incentives shape behavior. More complex, billable procedures generate revenue, while counseling or preventive care may not. 3. Prescription drugs, 10–15%. Prescription spending includes branded drugs, generics, specialty medications. Price negotiation occurs through insurers and pharmacy benefit managers, but patients often experience unpredictability in costs, especially for high-cost or specialty medications. 4. Administrative and billing costs, 8 to 12%. One of the largest invisible drivers of cost. Claims processing coding, prior authorizations, billing disputes. Studies show U.S. administrative costs are twice those of comparable countries, yet they do not directly improve patient care. 5. Long-term and post-acute care, 5 to 10%, includes nursing homes, rehab facilities, home health care. Population aging and chronic disease prevalence drive spending in this area. 6. Other services and public health. The remainder covers preventive care, public health initiatives, mental health services. Emergency preparedness, small individually but collectively essential. Structural insight. Looking at the buckets, one pattern emerges. Complexity drives cost. Hospitals and physician care dominate, but are themselves entangled with administrative and billing layers. Drugs and specialized services add unpredictability. Individuals and payers have little visibility into total flow. The next step is tracing the flow of a single dollar from paycheck to provider to make the system tangible. That's where things get almost counterintuitive and where the first real tension appears between intention and outcome. Healthcare in America, follow the money. Post 4, following the dollar. Step 1, the employer layer. The $100 is collected as part of payroll. The employer passes it along to an insurer. Even here, the dollar is split. Part covers the premium contribution from the employee, part comes from the employer's share. Often, employees never see this money. It's folded into total compensation. Step 2, the insurer layer. The insurer receives the full $100. What happens next? Provider network contracts. A portion is reserved to pay hospitals, clinics, and doctors who treat the plan's members. Pharmacy benefit managers, PBMs. Another slice goes to manage prescriptions, negotiate drug prices, and administer formularies. Administrative costs. Claims processing, billing support, compliance, and IT systems take their share. Reserves and profit. Insurers keep a portion in reserve or as profit. At this stage, the dollar has already been carved up multiple times before it reaches clinical care. Step 3, the provider layer. When a patient visits a clinic or hospital, the dollar arrives in pieces. The clinic receives its payment based on negotiated rates, not the sticker price. Some funds are deducted for administrative overhead, billing, or staffing costs. Denied claims or rejected charges may reduce the effective payment even further. By the time the provider gets the money, a substantial portion has been diverted to administrative friction rather than patient care. Step 4, the patient layer. Even after this, the patient often pays out of pocket. Deductibles, co-pays, coinsurance, out-of-network charges. This means the same dollar has been contributed multiple times, first through the paycheck, then through taxes if federal programs subsidize care, and again at the point of service. Structural insight. Following the dollar exposes a simple truth. Complexity drives cost. Each layer exists for a reason: regulation, risk management, negotiation, or compliance. But layering creates inefficiency. Patients, employers, and taxpayers see only fragments of the total flow, and yet the system appears opaque, expensive, and unpredictable, not because someone is hiding money, but because the machine is built to operate through multiple intermediaries. Next step. Now that we've traced the dollar, we can examine administrative bloat and its effect on clinical care. This is where the incentives of the system meet reality, and where we start to see why costs escalate without necessarily improving outcomes. Healthcare in America, follow the money post. 5. Administrative complexity, the invisible cost. American healthcare is enormous. We've seen who pays and where the money goes, and even traced a single dollar through the system. Now let's examine one of the largest, least visible drivers of cost: administration. Why administration exists. No single entity is to blame. Administrative layers exist because compliance requirements. Hospitals and insurers must follow federal, state, and local regulations. Revenue protection. Providers need billing, coding, and collections departments. Risk management. Insurers need claims review, denials, and appeals processing. Coordination. Multiple payers, network contracts, and patient eligibility require staff to manage flow. Each of these layers solves a problem, but each also adds cost. How it breaks down. Consider a typical hospital, clinical staff, doctors, nurses, therapists directly delivering care. Administrative staff, billing, coding, claims review, human resources, IT, compliance, legal revenue cycle management, collecting, processing, and reconciling payments from insurers and patients. In the United States, administrative costs account for roughly 8 to 12% of total healthcare spending. That's hundreds of billions of dollars annually, roughly double what similar countries spend. Doctors spend more time on paperwork than in almost any other system. Nurses and support staff spend hours on documentation and prior authorizations. This is why physicians burn out and hospitals struggle with margins, even when they are busy providing care. Administrative complexity versus clinical care. The problem isn't just cost, it's friction. Prior authorizations delay treatment. Coding errors trigger denials. Complex claim systems confuse patients. Every layer of administration increases time, effort, and uncertainty for everyone: providers, payers, and patients. In other words, money spent on administration doesn't directly improve outcomes, yet it is essential to keep the machine functioning. Why you should care. Administrative complexity is invisible to most patients. You see your bills, your deductible, your copay, but rarely the thousands of small interactions behind them. Following the dollar in the previous post, you now understand a significant portion of each premium and tax dollar never touches clinical care. It's diverted to manage, track, and control the system. This is the first clear point where incentives collide with outcomes. The machine works, but it also imposes invisible costs that no one directly sees. Transition. Next, we'll examine insurance design, where financial engineering meets patient experience. This is where the system's complexity begins to influence behavior, choices, and ultimately, cost. Healthcare in America, Structural Reform, Playbook Post 6, Technology and Telehealth Optimization. Technology in healthcare is often talked about as the next big fix, but without careful design, it can add complexity instead of reducing it. When implemented thoughtfully, tech and telehealth can improve access, coordination, and outcomes, completing the reforms outlined in this playbook. Why technology matters. Electronic health records, EHRs, and data integration reduce duplication and improve continuity. Telehealth expands access for rural and underserved communities. Remote monitoring supports chronic disease management and preventive care. Technology is a tool, not a solution in itself. Used strategically, it amplifies other structural reforms: integration, transparency, and incentive alignment. Key levers. Streamlined telehealth platforms. Simple, user-friendly interfaces for patients and providers. Integration with EHRs to ensure continuity and data flow. Focused use for follow-ups, consultations, and chronic disease monitoring. Remote patient monitoring devices track blood pressure, glucose, heart rate, and more data. Feeds into provider dashboards for timely interventions. Reduces preventable hospitalizations and complications. Data integration and analytics. Unified patient records. Improve care coordination. Analytics identify high-risk patients and resource gaps. Supports evidence-based decision-making and oversight. Why this matters for patients. More convenient access to care, especially in rural or underserved areas. Reduced travel and wait times. Better tracking of chronic conditions and preventive measures. Fewer surprises in billing or treatment, thanks to integrated systems. Structural insight. Technology alone won't fix systemic inefficiencies, but it enhances the levers already discussed. Integration becomes more effective. Administrative burden is reduced. Incentive alignment and preventive care are easier to track. When combined with oversight, transparency, and coordinated care, technology turns abstract reforms into real-world improvements that patients can see and feel. Closing the playbook. This concludes the Structural Reform Playbook. administrative oversight and waste reduction price, transparency and negotiation, integrated care and coordination incentive alignment for prevention and chronic disease, rural and underserved access technology and telehealth optimization. The series shows that practical, achievable reforms exist, even without overhauling the entire system. Small structural changes, applied thoughtfully, can reduce friction, preserve access, and improve outcomes. Healthcare in America. Follow the Money Post. 7. Chronic disease, the real cost driver. We've traced who pays, where the money goes, how a dollar moves, and insurance mechanics. Now we turn to the factor that drives most healthcare spending: chronic disease. 1. The scale of the problem. Chronic diseases, including diabetes, heart disease, obesity, and autoimmune conditions, account for roughly 70–80% of healthcare costs in the United States. Millions of Americans live with multiple chronic conditions. Treatment is ongoing: doctor visits, tests, medications, hospitalizations. Costs compound over time, often creating financial stress for patients and strain on insurers and providers alike. The system is designed to manage acute events well, but chronic conditions create persistent demand, exposing structural inefficiencies. 2. Incentives and misalignment. Fee-for-service care. Providers are reimbursed for procedures, tests, and visits rather than long-term outcomes. Preventive care under-incentivized, counseling, lifestyle support, and early intervention are often undervalued financially. Patient behavior versus system support, access, food systems, socioeconomic factors, and education all influence health outcomes, but the system primarily reacts to illness rather than preventing it. The result: the machine is built to treat disease efficiently, not necessarily to prevent it. 3. Chronic disease and costs. Hospitalizations, recurring admissions for complications, medication, often lifelong, especially for diabetes, hypertension, and heart disease, long-term care. As patients age, care needs increase, lost productivity, societal costs from absenteeism and disability. Even when the system works as intended, costs escalate because chronic disease requires ongoing resources. 4. Why this matters. Understanding. Chronic disease as a cost driver changes the conversation. It is not about villainizing providers, insurers, or patients. It is about structural incentives and the mismatch between treatment and prevention. It shows that high spending is not random. It reflects the persistent demand created by population health trends and system design. Do you begin to see a pattern? The machine isn't broken because of greed. It's stressed because of chronic demand and misaligned incentives. Next, we will examine rural healthcare and consolidation, showing how the same structural pressures hit small communities even harder. Hospitals close, services disappear, and the machine's complexity has real, tangible consequences for everyday Americans. Healthcare in America. Follow the Money Post. 8. Rural healthcare and consolidation. When the machine strains. So far, we've mapped who pays, where money flows, how a dollar moves, and explored administrative complexity and chronic disease. Now we see how these forces converge in rural America, where hospitals are small, margins are thin, and system complexity hits hardest. 1. Hospital closures. Over the past 2 decades, hundreds of rural hospitals have closed. Causes include low patient volumes, high uncompensated care, and increasing administrative burdens. When a local hospital closes, patients must travel farther for care, sometimes hundreds of miles for emergencies or maternity services. This is where the structural cost of complexity becomes tangible. Every layer of administration, insurance negotiation, and provider reimbursement adds to the financial pressure, threatening the survival of small facilities. 2. Consolidation and private equity. Many rural hospitals are acquired by larger health systems or private equity firms. Consolidation can bring resources and standardized care, but also centralized decision-making that prioritizes financial performance over local needs. Private equity ownership often emphasizes cost-cutting and profit margins, which can reduce staffing or eliminate underused services. The result: communities lose local services, and residents experience less access, all while the total dollars flowing through the system continue to grow. 3. Limited access and telehealth. Telehealth promises expanded access, but it cannot replace all in-person care. Broadband limitations, staffing shortages, and technology adoption challenges reduce effectiveness in many rural areas. Even when care is available virtually, the real-world friction remains: long travel times, delayed treatment, and fragmented services. 4. Structural insight. Rural healthcare exposes the tension at the heart of the system. Complexity and consolidation allow the machine to operate efficiently at scale, but small, low-volume communities lack the buffer to absorb costs and friction. High spending doesn't guarantee access. In fact, it can coincide with service loss. The system is not uniformly broken. It is stressed where scale, demand, and resources collide. With rural pressures laid bare, the next step is to examine incentives across the system. Who benefits from complexity, chronic disease, and consolidation? This sets up the final discussion on reform principles, where we start talking about solutions grounded in structure rather than ideology. Healthcare in America, follow the MoneyPost 9 incentive audit. Who really benefits? We've traced the system from dollars to delivery, explored chronic disease, and examined rural pressures. Now we ask a crucial question: who actually benefits from the way the system is structured? Understanding incentives is key to seeing why healthcare costs continue to rise, even when outcomes lag. 1. Providers, hospitals, and physician groups benefit when patients utilize services. More procedures, more visits, more tests. Fee-for-service payment models reward volume rather than long-term outcomes. Administrative complexity can create higher revenue for larger organizations that can manage it efficiently, leaving smaller providers struggling. Insight: scale and complexity often favor larger, well-resourced providers. 2. Insurers. Insurance companies benefit from predictable revenue through premiums and from managing risk pools. Complexity, deductibles, prior authorizations, network rules allows insurers to control costs and reduce risk exposure. Administrative layers are part of this management. They protect financial stability, but also add friction for patients. Insight: the system is designed to manage risk, not maximize simplicity. 3. Pharmacy benefit managers and drug manufacturers. PBMs negotiate prices and rebates, influencing which medications are accessible or costly. Drug manufacturers benefit from high-cost specialty medications and brand exclusivity periods. Insight: financial structures shape access and cost, sometimes more than clinical need does. 4. Patients benefit from insurance coverage, access to advanced care, and risk protection. Yet they also bear the cost of complexity: premiums, deductibles, co-pays, travel for care, and confusing bills. Insight: patients participate financially at multiple points but rarely see the full flow of funds, which reduces visibility and understanding. 5. Communities. Urban centers with high volumes and consolidated hospitals often maintain stable services. Rural communities with low volumes and fewer resources are vulnerable to closures and service reductions. Insight: structural scale advantages create unequal outcomes across geographies. Structural takeaways: complexity, consolidation, and financial engineering create winners and losers. The system works for efficiency and risk management, but not always for access, affordability, or simplicity. Understanding incentives is essential before discussing reform. Any solution must realign motivations, not just cut costs. With incentives mapped, we can now move to the final post: reform principles. Here, we shift from analysis to constructive thinking, outlining structural ideas that could reduce friction, improve access, and align incentives with health outcomes. Healthcare in America, follow the money post. 10 reform principles, aligning the system. We've traced the U.S. healthcare system from dollars to delivery, explored administrative complexity, chronic disease, and rural pressures, and analyzed incentives. Now the question becomes, what would a system look like if it aligned with outcomes rather than complexity? This is not about ideology or politics, it's about structure and function. 1. Simplification. Reduce unnecessary administrative layers. Streamline claims, billing, and prior authorization processes. Standardize coding and reporting where possible. Goal: money and effort should flow toward care, not paperwork. 2. Transparent pricing. Make costs clear for patients, employers, and payers. Standardize pricing across hospitals and providers where feasible. Ensure out of network and surprise bills are minimized. Goal: reduce confusion, improve decision making, and empower patients. 3. Incentive alignment. Reward preventive care and long term health outcomes rather than volume of procedures. Align provider reimbursement with patient health metrics and chronic disease management. Encourage insurers to focus on outcomes and accessibility rather than purely risk mitigation. Goal: make the system work for health, not just billing. 4. Rural stabilization support small hospitals and critical access facilities with scalable administrative support. Consider alternative models for staffing, telehealth, and regional collaboration. Protect essential services even in low volume communities. Goal: ensure equitable access regardless of geography. 5. Data driven oversight. Use data to identify inefficiencies, high cost drivers, and gaps in access. Encourage transparency in spending and outcomes across all layers. Support continuous improvement rather than static regulation. Goal: make evidence the foundation for policy and operational decisions. 6. Patient centered design. Simplify insurance interactions, educate patients on coverage, preventive care, and cost implications. Make navigation of care intuitive and friction free. Goal: ensure patients experience the system as a service, not a puzzle. Closing insight. The U.S. healthcare system is enormous, expensive, and complex, but it is not irredeemable. By focusing on structure, transparency, and incentives, it is possible to reduce waste, improve access, and align resources with actual care. The principles outlined here are nonpartisan and structural. They do not depend on ideology, politics, or personalities. They depend on understanding the machine and reshaping it to serve the people it was meant to help. This completes the Follow the Money series. Post 1, $4.5 trillion machine. Post 2, who actually funds the machine? Post 3, where the money goes. Post 4, following the dollar. Post 5, administrative complexity. Post 6, insurance design. Post 7, chronic disease. Post 8, rural healthcare and consolidation. Post 9, incentive audit. Post 10, reform principles.